Testing, 1, 2, 3. Testing, testing, testing. It's okay. Listen, I think.
Yeah, it's really kids. They're all serving governments. One of them is Russian linguist, international relations, master's in conflict resolution, which is somewhere between I think she's an older but then I have a son who's second in master's relations. Third is cybersecurity. She's finishing his
Just so you know, I'm giving people a few minutes to get in here after votes. So. I took a shortcut, I think. So. The subcommittee will come to order. Good afternoon, and thank you all for joining us. Before we begin, I'd like to ask unanimous consent for my friend and colleague and former committee member, Dr. Ralph Abraham, to sit on the dais and participate in today's proceedings. Without objection, so ordered. Today's hearing is the first of what I hope will be a series of hearings to examine specialty care access and quality in depth. Given the high rate of lower limb injuries and conditions among veterans of all ages and the issues this subcommittee has been discussing since 2015 regarding recruitment and retention among professionals trained to treat foot and ankle issues in the Department of Veterans Affairs, I thought it most appropriate to begin today with a discussion of lower extremity injuries, conditions, and treatment. Musculoskeletal injuries are the top concern among veterans newly separated from service in the armed forces, and are also a primary concern among older generations of veterans with conditions that may be exacerbated not only by military service, but also by aging and chronic illnesses like diabetes. According to a February 2017 VA white paper, almost 2 million veterans in the VA healthcare system are at risk for major foot wounds, infections, and amputations. And there is an increasing demand among VA patients, particularly those with polytraumatic injuries, spinal cord injuries, and major limb amputations for primary and specialty podiatric services. I ask unanimous consent to insert that white paper into the record. Without objection, so ordered. Given increasing demand, it is imperative now more than ever that VA be equipped with the highly trained workforce necessary to provide timely access to quality foot and ankle care within VA medical facilities. VA's ability to do that, however, is hampered by antiquated statutory requirements that have held podiatrists practicing within the VA's walls back and, as a result, limited access to podiatry care for veteran patients. The podiatry profession has been transformed over the last few decades, yet due to a law developed in 1976, 41 years ago, VA's podiatry practice has fallen far short of the private sector in terms of pay and advancement opportunities. According to VA, this has led to an inability to recruit and retain the most experienced podiatrists, the ones we want treating our most vulnerable veterans, as well as recent graduates just starting out. Needless to say, it has also led to lengthy hiring delays, averaging 14 months for new podiatry positions. At a time when veteran demand for foot and ankle care is growing, this is unacceptable. I have introduced a bill, H.R. 1058, the VA Provider Equity Act, that would address this issue by including VA podiatrists within the definition of VA physicians and, in turn, ensure that podiatry pay is more in line with industry standard and allow podiatrists to attain promotion and leadership positions in the VA healthcare system. Similar language passed the House last Congress, and for our veterans' sakes, I'm hopeful it will see the President's desk this Congress. During today's hearing, I look forward to hearing our witnesses and committee members' thoughts on H.R. 1058 and on what else this subcommittee can do to guarantee timely access to specialized foot and ankle care veterans have earned and deserve. I also want to discuss today how VA can improve the provision of both foot and ankle care and orthotic and prosthetic care in the community for veteran patients. As the American Orthotics and Prosthetics Association states in their written testimony, 90% of the orthotic and prosthetic care that our veterans receive is in the community. However, there are persistent concerns about care coordination and communication between VA and community providers treating veterans with major amputations. Unfortunately, this is not just an issue of concern for prosthetics. During a full committee hearing earlier this year, Dr. Dunn shared a story about a veteran constituent of his who delayed and disjointed experience seeking podiatry care through the CHOICE program led to an unnecessary, lengthy, and burdensome episode of care. I ask unanimous consent to insert that constituent's story into the record for this hearing as well. Without objection, so ordered. As we continue to move forward to develop the next generation of VA care and community programs, we must take those stories to heart and ensure that they are not repeated. I appreciate our panelists and audience members for being with us this afternoon, and I very much look forward to today's discussion. I will now yield to Ranking Member Brownlee for any opening statement that she may have.
Thank you, Mr. Chairman, and thank you for holding today's hearing. The ability of the VA to hire and retain skilled medical professionals to treat veterans with lower extremity medical conditions is vitally important. Many veterans receive VA care have lost limbs due to combat. Others develop serious medical conditions affecting the lower extremities later in life due to their military service. These conditions and injuries can significantly affect a veteran's quality of life. I want to thank Chairman Winstrup for being willing to work in a bipartisan way to address this issue impacting the VHA and the veterans it serves. I appreciate his insight into the issue as a podiatrist and appreciate his leadership on this issue as chairman. The number of veterans receiving amputations has tripled since 2000, according to the VHA amputation system of care. While many of these amputations were the result of injury, some were the product of a preventable or treatable illness or disease such as diabetes, hypertension, or obesity. Podiatrists often act as the first line of defense against these types of illnesses by providing preventative care that allows veteran patients to improve their quality of life and avoid amputation. I look forward to the discussion today. I hope that we may use the testimony and information we receive to shape solutions to these pressing problems. We cannot expect to solve the VHA's access problems without the providers, supplies, and resources that are urgently needed. I look forward to continuing the bipartisan work on this issue in this committee, and I yield back.
Thank you. We are fortunate today to be joined this afternoon by several distinguished witnesses. Joining us this morning on our first and only panel is Dr. Stephen Goldman, the president of the American Board of Podiatric Medicine, Dr. Seth Rubenstein, Treasurer of the Board of Trustees and immediate past Chairman for the Legislative Committee for the American Podiatric Medical Association. Dr. James Fickey, the Chairman of Orthopedic Surgery at Johns Hopkins School of Medicine and a member of the American Association of Orthopedic Surgeons and the American Orthopedic Foot and Ankle Society. Jeffrey Brandt, Chief Executive Officer and founder of Ability Prosthetics and Orthotics, and a member of the American Orthotics and Prosthetics Association, and Dr. Jeffrey Robbins, the Department of Veterans Affairs Chief of the Podiatry Service. I want to thank you all for being here today and taking time from your schedules to join us. Dr. Goldman, we'll begin with you, if you will, and you are now recognized for 5 minutes.
At the outset, I would like to express my appreciation for the honor to address this committee today. In discussing this topic, I do so as a private citizen, not as the Chief of Podiatry and the Director of a Podiatric Residency Training Program at a Veterans Administration Medical Center. I do so not as the former Interim Chief of Surgery or the Site Director of Surgical Services at a second VA medical center. And I do so not as a retired Lieutenant Colonel in the United States Air Force who served as a podiatrist and also as a Surgical Operations Squadron Commander for the last 40 of my 20-year career in the Air Force. I'm testifying as a private citizen, one who graduated almost 35 years ago and was an associate professor at the New York College of Podiatric Medicine for nearly 15 of those years, during which time I've witnessed firsthand the metamorphosis of my profession. I'm currently the president of the American Board of Podiatric Medicine, and in this position I represent thousands of podiatrists across the country, many of whom are employed by the federal government. As a veteran myself, I am also now the consumer of the medical services of the system about which you have invited me here to testify. I have witnessed the best of our profession as it has grown over the past 35 years since I graduated in 1982. I am in awe of how far we have come. Today, all graduating podiatrists are 3-year residency trained in podiatric medicine and surgery, and we are integral parts of the collaborative healthcare delivery system, providing essential services alongside our distinguished allopathic and osteopathic specialists. Today's podiatrists manage the complex nature of foot and ankle deformities and are part of the multidisciplinary team serving the needs of a seemingly ever-growing diabetic population. We take call, provide inpatient and outpatient care, respond to emergencies, prescribe medications, and independently perform surgery of the foot and ankle. Fundamentally, we perform a vital role in the continuum of healthcare equal to other physicians, often for a patient population whose choice for healthcare is only the VA. More often than not, those patients present with more multiple comorbidities than the average population. In the Veterans Administration, podiatry is often the first specialty consulted for foot and ankle services, and we provide more of these services than any other specialty. Podiatrists in the private sector have witnessed salaries commensurate with the profession's growing skills. By contrast, salaries in the Veterans Health Administration, VHA, have not kept pace, and the gap grows larger every day. Podiatrists in 42% of the regions across the country have reached legislatively capped rates of pay under VHA. What that practically means is that a podiatrist at the absolute top end of the pay charts will earn exactly the same as much less senior podiatrist, with no hope of ever being further remunerated commensurate with the added time of service or experience. Podiatrists are defined as physicians under Title 18 of the Social Security Act, Section 1861, R3. The VA definition of podiatry is a vestige of a 41-year-old, antiquated 1976 VA omnibus bill and is sorely outdated. Consequently, podiatry salaries under VA Health Administration are locked into that same 41-year-old pay scale. As a result, it is becoming increasingly harder to fill positions and keep people with the vital skills under VHA. I think we can all agree that all of us, but particularly our veterans, deserve the very best of care. When looking at the bell curve for salaries in podiatry on salary.com, virtually no matter where you look by zip code, podiatry salaries in federal services are in the lowest 10 to 15% of that curve. Podiatrists in leadership positions within the administration have been members of pay panels, making salary decisions for their medical colleagues who enjoy salaries that are at the very least 40% greater than the top-end VHA podiatry salaries. Heretofore, the demographic for those seeking employment under VHA used to be board-certified seasoned professionals who came with many years of experience and who wanted to make careers in federal service. Podiatrists currently employed by VHA remain in the system primarily for one of two reasons: Either they have a refined sense of purpose and wish to give of themselves out of a sense of commitment to our veterans, or they do so because they themselves are veterans and they are compelled by a continued sense of mission, tending to the medical needs of their comrades in arms. I have said many times the VA hospital system is the only healthcare system that I've ever known where you will see a patient with one leg being pushed to his appointment in a wheelchair by a patient or volunteer with one arm, and they don't know each other. Veterans get this. These good-hearted providers are getting harder to find and even harder to keep. Podiatrists with less than 10 years of experience make up 60% of the new hires at VHA. The VHA podiatry workforce has effectively become the private sector's farm team, now being filled by younger, often non-board certified providers who seek to acquire the required case volume and diversity to qualify to sit for their board certification examinations. And after passing, take those skills to the private sector where they can make a fair wage in order to repay a student debt burden that often averages and exceeds $194,000. Specifically, in 2016, only 30% of new hires were board certified. Until we can offer better compensation, this has and will continue to trickle down to affect patient access because skilled, board certified, experienced practitioners can manage larger patient populations more efficiently than inexperienced younger professionals. To make matters even worse, in 2016, the VA's average delay in hiring a podiatrist to fill a vacant position was 14 months. That means 14 months of patients having to seek care elsewhere or forego necessary foot and ankle care altogether. Based on the salary.com data mentioned earlier, the takeaway message is that the VA's top-performing podiatrists, those making the highest possible salaries in VA, are paid about 25% less than the median salaries of their non-VA counterparts, and in most cases, only about half of what the top non-VA performers earn. In hospital leadership positions, both in the public and private sectors, podiatrists have had the oversight of numerous surgical and medical subspecialties, utilizing an insight of core and fundamental medical and surgical principles. These principles, coupled with consultation and input from the chiefs of the respective medical and surgical colleagues that they oversee, provide for an effective leadership model. Should a podiatrist be the chief of a subspecialty like neurosurgery or orthopedics, the answer has to be no, more than a neurosurgeon or orthopedist should be the chief of podiatry. But that does not mean a podiatrist who is the overall chief of all the surgical subspecialties can't work with and oversee and provide effective administrative leadership of those departments with collaborative input from the subspecialties with whom they work. In conclusion, Dr. Chairman, Ranking Member, and members of the committee, I thank you again for inviting me here to share my thoughts with you all and for your efforts and your desire to discuss this topic to hopefully right this inequity. I'm available to address any questions you may have for me.
Thank you, Dr. Goldman. Dr. Rubenstein, you're now recognized for 5 minutes.
Brownlee and members of the subcommittee, I welcome and appreciate the opportunity to testify before you today on behalf of the American Podiatric Medical Association. I commend the subcommittee for its focus to assist and direct the Veterans Administration to effectively and efficiently recruit and retain qualified medical professionals to treat veteran patients and improve access to quality health care in the VA. I am Dr. Seth Rubenstein, member and trustee of the American Podiatric Medical Association. I am before you today representing the APMA, the podiatric medical profession, and specifically our members currently employed and those seeking to be employed by the VA. I do not represent the Veterans Administration in my capacity today, though I bring with me knowledge of widespread disparity between podiatric physicians and other VA physicians. Dr. Chairman, the VA's qualification standards for podiatry were written and adopted in 1976. Podiatry starkly contrasted with other physician providers of the time, and for that matter, with what podiatry is today. Unlike 41 years ago, current podiatric medical school curriculum is vastly expanded in medicine, surgery, and patient experiences and encounters, including whole body history and physical exams. Back then, residencies were few and not required for licensure. Today, there are mandated, standardized, comprehensive 3-year medicine and surgery residency positions of sufficient number to satisfy the full number of our graduates, with 63 positions housed within the VA, each requiring completion of a broad curriculum comparable with medical and osteopathic residency training. Today's podiatrists are appointed as medical staff at the vast majority of hospitals and may serve in leadership roles within those institutions, including but not limited to chief of staff and chief of surgery. Podiatric physicians also serve as members of their state medical licensing board. Many of my colleagues have full admitting privileges and are responsible for emergency and trauma call. The competency, skill, and scope of today's podiatric physicians has vastly improved since 1976. Because of this, CMS recognizes today's podiatrists as physicians, and TRICARE recognizes us as licensed independent practitioners. The veteran patients we treat, often plagued by socioeconomic and psychosocial issues, are ailing, have more comorbid disease and disproportionately poor health status compared with their non-veteran counterparts. Such patients suffer from a greater burden of diabetic foot ulcers, amputations, and associated complications. As documented in my written testimony, almost 2 million veterans are at risk of amputation, secondary to diabetes, sensory neuropathy, and non-healing foot ulcers. Dr. Chairman, the veteran population is far more complex to treat than patients in the private sector. One of the major missions of podiatrists as providers of lower extremity care is amputation prevention and limb salvage, which provides a cost savings to the VA and plays an integral role in a veteran's quality of life. As part of an interdisciplinary team, podiatrists independently manage dermatologic, rheumatologic, and orthopedic pathology and trauma within our relative scope of practice. We assume the same clinical, surgical, and administrative responsibilities as any other unsupervised medical or surgical specialty. Despite this equality in work responsibility, there exists a marked disparity in the recognition and pay of podiatrists as physicians within the VA. The majority of new podiatrists recently hired within the VA have less than 10 years of experience and lack board certification. Majority of these individuals will separate from the VA within 5 years. 7 years ago, APMA leadership made VA recruitment and retention a top priority. Since then, we have alerted the VA to our concerns, and in response, former Undersecretary Petzel created a working group with whom we participated in several meetings, and from whom we received support for a legislative solution to address this issue. I come before this committee today to respectfully request that Congress help the VA and its patients by passing legislation to recognize podiatric physicians and surgeons as physicians in the Physician and Dentist Authority. We believe that changing the law to recognize podiatry, both for the advancements we have made to our profession and for the continuing contributions we make in the delivery of lower extremity care for the veteran population, will resolve recruitment and retention problems for the VA and for veterans. Dr. Chairman and members of the subcommittee, thank you again for this opportunity. This concludes my testimony. I'm available to answer your questions.
Thank you, Doctor. Dr. Fickey, you're now recognized for 5 minutes.
Ranking Member Brownlee and members of the subcommittee. On behalf of the American Association of Orthopedic Surgeons, which represents over 18,000 board-certified orthopedic surgeons, and the American Orthopedic Foot and Ankle Society, which represents over 2,200 orthopedic surgeons specializing in foot and ankle disorders, I thank you for the opportunity to speak to you today about lower extremity care for veterans. My name is Colonel James Fickey, retired, and I am an orthopedic surgeon specializing in foot and ankle care. I'm currently the chairman of orthopedic surgery at Johns Hopkins School of Medicine. I served in the United States Army for 30 years, deploying to Iraq from 2004 to 2005 as the deputy commander and chief medical officer for the 228th Combat Support Hospital in Mosul. I have led the Extremity War Injuries Project Team for 12 years, an effort focused upon improving care of warriors who have sustained battlefield injuries. This effort has identified the gaps in knowledge as well as research needs that have shaped the generous congressional funding of over $330 million for veterans with limb injuries commonly sustained in combat. There are many orthopedic surgeons serving the veterans proudly through the VA and many others caring for veterans through the CHOICE program. Orthopedic surgeons play a role in saving limbs, reconstructing function, and returning veterans to a healthy, active lifestyle. The AAOS, was honored to receive a Joint Warfighter Program Award in collaboration with the Major Extremity Trauma Research Consortium, the purpose of which was to determine the best evidence for treatment of injuries to our warriors, including lower extremity injuries. We are honored to receive that support with your effort, through your effort, Dr. Chairman, and we appreciate your many years of support for orthopedics and our patients. We acknowledge the significant need for access and for care of veterans through the VA with lower extremity conditions. Current statistics are staggering regarding the burden of injury and the disability. My own teams have reported and published literature showing that up to 92% of warriors with battlefield injuries will have permanent disability of the musculoskeletal system. As of 27 April 2017, 6,920 men and women have given their lives in the defense of our Constitution, and 52,540 men and women have sustained wounds in action, of which as many as 80% involve a limb injury, and many of these are lower extremity. We absolutely agree that musculoskeletal care for veterans is imperative. We will only meet these needs with a strong force of well-trained providers of all backgrounds, including podiatric surgeons and physicians and orthopedic surgeons. Concerning H.R. 1058, the VA Provider Equity Act, the orthopedic surgeons of the AAOS strongly agree and support the high-quality podiatric surgeons that should be more equitably compensated to support their recruitment and their retention. Podiatrists are an essential part of the care team at the VA and provide excellent service to veterans. During my service in the Army, I practiced alongside podiatrists in many military bases and had a podiatric surgeon on my staff at Mosul, who served in a non-clinical leadership role, Lieutenant Colonel John Gowan, Doctor of Podiatric Medicine. This American Association of Orthopedic Surgeons and the Orthopedic Foot and Ankle Society are concerned with two aspects of the legislation that are not essential to the goal of paying podiatrists what they're worth at the VA. Firstly, this legislation would label podiatrists who have the Doctor of Podiatric Medicine, or DPM, within the VA as physicians, including them in the category currently reserved for doctors of medicine and doctors of osteopathy. Secondly, the bill would allow DPMs to attain clinical leadership positions over MDs and DOs. Podiatrists and orthopedic surgeons are trained differently. The lower extremity is one of the more complex areas of the human musculoskeletal system, and an orthopedic surgeon will attend 4 years of medical school, serve a 5-year orthopedic surgery residency, and then typically take an additional year of subspecialty fellowship training. All MDs and DOs are trained in multi-system clinical care and disease management, which is not the case for all podiatrists, and is a prerequisite for peer review of physicians. While recent changes have improved podiatric education, it is not the same as a multi-system medical education required to become a DO or an MD, and nor is it the same accreditation process. Podiatry does not participate in the United States medical licensing examination, which is the standard for all advanced medical care and essential to practice as a physician. We believe that the title of physician should be attained through the accreditation process and not the legislative process. The AAOS and the AOFAS stand ready to work with the subcommittee in good faith to improve this legislation and to improve the care of veterans provided by both orthopedic surgeons and podiatric surgeons. Thank you for the opportunity to appear before the subcommittee and for your work on behalf of our nation's veterans. I look forward to answering any questions you may have.
Thank you very much, Dr. Fickey. Mr. Brandt, you're now recognized for 5 minutes.
Chairman Wenstrup, Ranking Member Brownlee, and members of the committee, thank you for inviting AOPA's insights regarding lower extremity care for veterans. My name is Jeffrey Brandt, and I'm the CEO of Ability Prosthetics and Orthotics. We work with 7 VAMCs to provide prosthetic and orthotic services to veterans across VISNs 4, 5, and 6. Nationally, 80 to 90% of the veterans' orthotic and prosthetic care, known as O&P, is provided within the community. The private sector's procurement relationship with the VA and its workforce must be a part of any discussion of care for veterans with limb impairment or loss. TBI and amputation are signature injuries of Iraq and Afghanistan. As of June 2015, more than 327,000 service members had suffered a TBI, which can require orthotic management. More than 1,600 amputations had been performed for wounded warriors, with 80% affecting one or both limbs. But most amputations are a result of diabetes or cardiovascular disease. In 2016, the VA served 89,921 veterans with amputations. 78% of those veterans undergoing amputation last year were diabetic. AOPA commends the VA for its leadership granting access to advanced prosthetic technology, often before Medicare or private insurance. AOPA is also deeply grateful to the VA for rejecting a devastating prosthetics proposal put forward by the Centers for Medicare and Medicaid Services in 2015. When it comes to O&P care for individual veterans, in my experience, it is very uneven. Some VA MCs have excellent clinicians, embrace innovation, and maintain cordial working relationships with the private sector providers providing the majority of the care to veterans. In other places, VA staff appear not to be very knowledgeable about O&P. Some treat private providers as though we're competing for patients, or we're just in it to take advantage of the taxpayer. There are many advantages to veterans from the private sector partnership in O&P. Veterans receive the care they need more quickly. Care can be provided closer to the veterans' homes or workplaces. We often adopt cutting-edge practices and implement innovations earlier than our federal agency colleagues. For example, at Ability, every new patient receives 3 objective evaluations to establish their K level, or capacity for activity, and determine what technology is appropriate given that classification. But the VA very often does not use such tests or even a consistent approach in determining those K levels. Frequently, the VA won't accept our evaluation, or if we have more O&P expertise and are using a more rigorous evaluation. If we call or write the VA to say our evaluation shows that the patient is, for example, a K2 and wouldn't benefit from microprocessor-controlled technology, we often hear comments like, to be on the safe side, all my patients get that technology. Conversely, when our evaluation shows the veteran needs more advanced technology than the VA perhaps recommended, we find ourselves accused of lining our own pockets. At that point, I have a choice. I can continue to advocate for my patient at the expense of my relationship with the VA, or I can fill a prescription my assessment tells me is not best for my patient or ideal. If the veteran comes back 10 times in the next 6 weeks because the prosthesis wasn't fit properly, then the veteran hasn't been served, and our reputation is damaged. All of this could be averted by use of proper clinical protocols by the VA and better collaboration with outside providers. Sometimes patients come to us having heard about new technology. It's hard to tell a patient he or she doesn't need the device that was featured on a magazine cover. Our tests and data help patients understand and accept those difficult determinations. The VA, with its concerns of fraud and abuse, should welcome an approach that objectively determines patients' needs. I do see some things changing, though, slowly in some parts of the VA. Some recent RFPs have more emphasis on outcomes, data, and objective evaluations. But that change is uneven and slow, and it's the veterans who suffer the most with those delays. Now I'd like to turn to a challenge facing both the VA and private sector providers, and that's maintaining a highly qualified workforce. Demand for O&P is increasing. Experienced clinicians are retiring, and we've got a shortage. Already in California and Florida, an advertised opening can take longer than 12 months to fill. Currently, 13 universities offer O&P master's degrees, graduating fewer than 250 students annually. These positions pay good wages and can't be outsourced overseas, but master's programs are costly to expand. The Wounded Warrior Workforce Enhancement Act, introduced with bipartisan support by Representative Cartwright in the last Congress, would help. This bill is a limited, cost-effective approach to assisting universities in creating or expanding accredited O&P master's degree programs. Priority is given to the programs that have a partnership with the VA or DoD facilities, so students learn to respond to the unique needs of service members and veterans. We need this bill, and I ask for your support. AOPA looks forward to working with you to meet the needs of veterans with limb loss and limb impairment. No veterans should suffer from decreased mobility or independence because of lack of access to high-quality care, regardless of where it's provided. Thank you for considering my comments today. I'd be happy to answer any of your questions.
Thank you, Mr. Brandt. Dr. Robbins, you're now recognized for 5 minutes.
Thank you. Good afternoon, Chairman Winstrup, Ranking Member Brownlee, and members of the subcommittee. My name is Jeffrey M. Robbins, and I am the National Program Director of Podiatry Services for VA Central Office. Thank you for the opportunity to discuss lower extremity injuries and conditions among veteran patients and the ability of VA to recruit and retain high-quality providers. VA's podiatry service is dedicated to the mission of providing high-quality foot and ankle health care to veterans. In fiscal year 2016, the podiatry service cared for some 577,000 unique patients in over 1.4 million encounters. This is a 12% increase over fiscal year 2014. Podiatrists treat a wide variety of conditions, including major foot deformities from both battle and other service-related injuries to wound and amputation care for those with traumatic and chronic disease-related amputations. Podiatry service performed almost 16,000 operating room procedures in fiscal year 2016 alone. In addition to my role as National Program Director for Podiatry Services, I am also the National Chairman for VA's Amputation Prevention Program, currently called Prevention of Amputation in Veterans Everywhere, or PAVE. The VA has been engaged in amputation prevention since 1993, after Public Law 102-405 in 1992 established the importance of high-quality amputee and identified veterans with amputations as a special disability group. In 2006, the VA Oversight Committee recognized that we needed to address new traumatic amputees from Operation Iraqi Freedom and Operation Enduring Freedom. In order to determine those needs and write effective policy, I have visited Walter Reed to speak with veteran amputees, their families, and their caregivers. As a result of those conversations, the 2006 directive on this matter added a mandatory offer of a mental health consultation to any veteran who had or was about to undergo an amputation. This consultation was aimed to address the adjustment disorder common in those who have lost a limb regardless of cause. In 2012, the VA's Amputation Prevention Program was identified as an innovation by the Amputation Coalition of America, not only for its evidence-based program, but also for its continuous quality improvement. In fact, the latest directive was signed on March 17, 2017. VA cares for 1.7 million veterans at risk for amputation, of which 1.5 million suffer from diabetes, 46,000 suffer from end-stage renal disease, and 617,000 have peripheral vascular disease. Overall, VA treats over 66,000 patients yearly who have suffered an amputation, with more than 6,000 veterans having undergone an amputation in fiscal year 2016. Podiatry services are provided in 134 medical centers and many VA community-based outpatient clinics, and VA Podiatry is an extremely hard-working service. However, our compensation system has fallen behind the times, as the current pay authority is over 41 years old and was established when podiatric medicine was a very different profession. As a result, it has been increasingly difficult in the past several years to recruit and retain experienced providers. To illustrate this point, in fiscal year 2015 and 16, we brought in 142 new hires for a net gain of 54. What this means is that 88 providers left the system, or almost 62% of medical centers had to replace providers, disrupting patient continuity. Additionally, in 2016 alone, the National Podiatry Standards Review Board processed 53 new hires. Of those 53 new hires, 66% had less than 10 years of experience, and only 30% were board certified. The pattern has emerged that in the past several years is one of young providers coming into the system, gaining experience as well as their cases for board certification, becoming board certified, and then leaving for the private sector, where the average compensation is $30,000 higher than the highest compensation in VA. In fact, 58% of our pay regions have reached a legislative cap, established in 1976, making it extremely difficult to recruit and retain staff. The podiatrists that make up the VA podiatry services are all proud to provide the best care they can to Americans' veterans. We are also proud that this includes many veterans within our ranks. As a service, we are dedicated to continuous improvement and continue to look for ways to improve how we care for veterans. As such, the Department of Veterans Affairs supports H.R. 1058, the VA Provider Equity Act. Thank you for this opportunity to address this committee, and I look forward to your questions.
Thank you, Dr. Robbins. Thank all of you. I'm going to now yield myself time for questions and comment. First of all, Mr. Brandt, I want to thank you very much for your testimony today, and I look forward to working with you and your profession on how we can increase capabilities and fulfill the needs of so many of our veterans, and those numbers, as you know, are growing, and the need for your profession is greatly needed. On the podiatry issue, it first came to my attention, not really because I'm a podiatrist, but because I serve on this committee. And it was brought to our attention by Secretary McDonald during the last term that there was a tremendous shortage of podiatry, there was a reason for the shortage, and the need was tremendous. And at that time, the Secretary and his staff put together a paper on the idea of being able to fix this problem by moving podiatric physicians and surgeons into the category of physicians and surgeons, which they are under Medicare and throughout the states. And that would solve the problem, increase the pay, and the problem would be solved. We ran into some roadblocks in the Senate, as we did get a bill to do that through the House of Representatives. You know, first of all, I want to say that this is not about the provider as much as it is about the patient. This is about the veteran in need of care. And you're going to hear of situations and the long waits, and you've heard about it today, for so many that seek the expertise of podiatry. And this is about recruitment, retention, and therefore access for our veteran patients. We say do no harm. Right now, those that are being harmed are our veterans that do not have access to podiatric care because of the inability of the VA to recruit and retain in the way that they could if this problem was corrected. So I thank the Secretary and the current Secretary for their VA paper, which is now in the record. I want to be clear. This is not a scope of practice issue. This is not about expanding the realm of credentialing that a podiatrist has or has had. It's about access. Access that is stymied by a classification, by a limited career path for podiatrists, and opposition that has come against the notion of moving podiatrists into the category of physicians and surgeons. We talk about education. Podiatry is a medical school curriculum, 4 years, after 4 years of college. During that medical school curriculum, there is 2 years of lower extremity biomechanics that is unique to the profession. There is a 3-year surgical residency. When completed, podiatrists have a full prescribing license, and they are licensed to do complete body history and physical examinations. Now, that isn't because it was just granted, it's because it's part of the training. Just for some comparison, because I'm listening to some of the things that were said, so I have a question for Dr. Fickey. You have, within the American Academy of Orthopedic Surgeons, a foot and ankle society. Is that correct?
Yes, there's a foot and ankle society.
Okay, and you are a member of that?
That's correct.
Okay. Is there a board that you need to take to become a member, like there is for hand, say, within orthopedic surgery?
There is a board of orthopedic surgery, and I sit on that board. I write questions for that board as a foot and ankle surgeon. Okay. When one is in the process for which you're asking the person is eligible at the completion of 5 years of orthopedic surgery residency, they sit for a written examination. I am one of the question writing task force for the written questions. After 2 years of case collections, those cases are collected and submitted. Those cases are peer reviewed. When a person has a specialty of foot and ankle, like hand, they sit for their ABOS, the American Board of Orthopedic Surgeons, on a panel of fellowship-trained, board-certified orthopedic foot and ankle surgeons at the end of 2 years of collection. When they succeed in the oral boards, which is, again, 2 years after a 5-year residency, they are qualified as American Board of Orthopedic Surgeons. There is not a certificate of additional qualification for foot and ankle
Specifically
surgeons.
for foot and ankle. So when do you need to do, there are 1-year fellowships after the 5-year residency in foot and ankle that are available?
That's correct.
Does everyone in the society, are they required to complete that fellowship?
Everyone in the, which society? Or the Foot and Ankle Society? No, the Foot and Ankle Society is by its constitution embraced for anyone who has a practice or is an interest in foot and ankle surgery after they've
But not
completed
specifically the
a foot and
fellowship
ankle.
like that you have completed? And
That is not a requirement for the Foot and Ankle Society.
okay. And I hope things have changed because I'm looking at a study. You're familiar with Foot and Ankle International? Is that an orthopedic journal? Now, this was a while ago, so maybe things have changed. And your process for foot and ankle sounds like it's up to the same measure that exists for podiatry as far as oral exam, written exam, and case presentation. But this abstract from this article, Foot and Ankle Experience in Orthopedic Residency, says, current residency training in the United States does not universally require commitment to foot and ankle education. A large number of residency programs do not have a faculty member committed to foot and ankle education, and almost 1/3 have no time specifically allocated to foot and ankle education. Is that changed in orthopedic residencies?
Dr. Chairman, could you tell me the date of that
Yeah, it was a
publication?
while ago. It was 2003.
2003, yes, I'm familiar with that study. As a result of 2003 paper, which is, as 14 years ago, there's been a radical change in education. The Foot and Ankle Society as an organization has put out a series of lectures, and really everyone who is board certified in orthopedic surgery is required to do a series of milestones. And the Milestones Project is accredited, the ACGME, the American Council on Graduate Medical Education, is really the entity that reviews the milestones, and the milestones, including foot and ankle surgery, require a rotation and require a certain number of minimums.
So since that time,
Radically changed, similar to the podiatry residencies
yes.
that we all agree have changed.
okay.
Yep.
One of the things that this is for Dr. Goldman, and I want to know if you agree with this statement or not. From Dr. Fickey, it says, MDs or DOs participate in active clinical care and multi-system trauma and disease management, which is not the case for all podiatrists and is a prerequisite for peer review oversight. Would you agree with that's not the case for all podiatrists today?
If you could repeat the question, sir, I'm sorry.
Yeah, well, the comment was that do podiatrists basically actively participate in multi-system trauma and disease management in their training?
I would say we do, along with our medical colleagues. Certainly, we have scopes of practice that we all work within, and with that, certainly there's a collaborative effort with any system condition that we may experience, whether it be infectious disease, primary care, internal medicine, vascular surgery, that we will collaborate that effort.
And participate actively in the care of that patient.
Yes, sir.
Correct, especially in residency training. Dr. Fickey, you had a concern, I believe, when we talked before and today about the administration roles of podiatrists. I think your concern predominantly was clinical oversight, podiatrists over orthopedists, or for that any other specialty. Dr. Robbins, could you clarify for me, can a podiatrist have clinical oversight over an orthopedic surgeon in the VA?
No, not clinical oversight. That's actually a Joint Commission requirement that peers evaluate peers. So, for example, if a urologist was a chief of surgery, they couldn't do an ongoing professional practice evaluation on an orthopedist, or a psychiatrist couldn't do it, and so on. Sure. That has to be peer-to-peer.
And that makes sense to me. You should be able to be within your own section. So as far as that concerned, it sounds like you can't do it anyway. So hopefully that's clarified. And I would agree with that 100% with you, Dr. Fickey. I want to applaud you for your 30 years, I believe, military service, your deployments, and all that you have done for our troops. And I've enjoyed working with you on many issues and hope to continue to do that. We may have a little disagreement here on some things today, but I do extend that and truly mean that. One of the things, you talked about your roles in theater as deputy commander. I also served as a deputy commander of clinical services. I was the assistant to the DCCS, but for 3 months I was the DCCS and served at the same time as chief of surgery in that role, and things went well. And I think it's a small world story to be able to say that I was appointed to those positions by your medical school roommate, Jim Terrio. So I just wanted to clear some things up, and I want to give other people a chance to ask their questions. And with that, Ms. Brownlee, you're now recognized.
Thank you, Mr. Chairman, and I would agree with all of your arguments around the need for more services to our veterans. The only thing I would take objection to is when the problem arises that you weren't sought out because you were a podiatrist, but because you were a member of the committee. I think it has to be both. Anyway, I wanted to ask Dr. Robbins, you gave some statistics about the rise of pediatric need within the VA. Can you just give me a quick explanation why that increase has occurred? It's pretty significant.
It is quite significant, and partially due to returning vets from the three theaters now, Operation Iraqi Freedom, Operation Enduring Freedom, and Operation New Dawn, with new problems. These are young people, very complex problems. They want to stay active, and they require, especially if they have lower extremity injuries, they require good podiatric biomechanical care. We also have a significant aging population that are coming to us with diabetes, end-stage renal disease, peripheral vascular disease, that are at extremely high risk for amputation. VA also takes a much more enlightened approach about what kind of basic foot care we provide. So veterans who are blind can't get podiatric care in the private sector. Patients who have dementia cannot get podiatric services in the private sector. Patients who have movement disorders like Parkinson's, anticoagulation therapy, severe debilitating arthritis. We expanded that scope of eligibility for veterans back in 2002, as we saw that, especially with the aging population coming down the pike, that they were also at risk for amputation, and more importantly, for quality of life. When you lose the ability to walk, your life expectancy goes down significantly. So we expanded that, and that's the reason that we are seeing increasing numbers of veterans seeking podiatric care.
Thank you very much. And in terms of the salary schedules within the VA, it's my understanding that they have been in effect since 1976. Is that correct?
Yes, ma'am.
And as someone responsible for these services to veterans, why is it that this hasn't been revisited in terms of salary schedules?
I've actually revisited for the last 11 years, writing legislative proposals to move podiatry into the same pay authority as other physicians and dentists. What has occurred is that we have gotten full support through VHA, but when it got up to VA and OMB, because it had a price tag on it of any sort, it was kicked back. In addition to that, the OMB looked at it and said, well, it looks like you can hire new podiatrists. We don't really care about their experience. It appears you can hire podiatrists. So that also, when I made the argument that we can't hire highly experienced providers, that we are getting inexperienced providers or older providers without board certification, that sort of fell on deaf ears, and here we are 11 years later.
Thank you for that. It seems like it's been an ongoing issue. Dr. Fickey, if you could talk a little bit about, I think you mentioned it in your testimony, and I only have a minute left, but if you could talk a little bit about going back to the accreditation requirements and, comparing the two. But could you kind of explain the barriers from your vantage point, barriers a podiatrist may have in providing administrative oversight and leadership as a medical director?
Yes, ma'am. I'm seeing 30 seconds to try to answer this. We'll do our best. The question, first of all,
given us a little more time.
Thank you, Dr. Chairman. And to attribute this, Dr. Chairman mentioned that he served as the Assistant Deputy Commander for Clinical Services, and I will attest that that at that time, Lieutenant Colonel and now Colonel, congratulations, sir, Wenstrup did a fantastic job, and by our mutual friendship with Jim Terrio, who was the deputy commander, said he was exceptional. There's no question that leadership is a character quality. Congressman Wenstrup demonstrates that. We all would agree. Leadership is as a character quality, has nothing to do with orthopedic surgeons, podiatric surgeons, or any other training. It is a character quality, bar none. So the obstacles to these really have to do with administrative leadership, which is, as I've said, and we all agree, chief of staff, commander of a hospital, president of a hospital. Those are roles that offer leadership enticement, and we completely agree that those are roles that if they provide incentives that are non-monetary, but job satisfaction for any provider, especially in this situation, podiatric surgeons who we need in the VA, we completely endorse that. I hope that answers your question.
It does. Thank you, and I yield back.
Dr. Dunn, you're now recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you also to the members of our expert panel here for devoting your time and your expertise to our veterans. Colonel Fickey, I'm impressed by the vast, I too am impressed by the vast body of your military service and accomplishments. I served in the U.S. Army Medical Corps same time as you did. I'm sure I don't recall crossing paths with you, but it's a big Army. I think it'd be fun for us to get together sometime, swap social stories. I want to ask you a couple of questions, and please don't take any umbrage if it appears that I'm disagreeing with your conclusions. I'm just trying to understand how you arrived at those conclusions and how important you think your conclusions are to the questions that we're addressing here today. So the first one was you evinced a concern that the term physician would be used to refer to podiatrists. I've been a civilian for over the last 20 years, and in the civilian world, the term physician has long since left the barn. It has migrated to a wide variety of healthcare practitioners. As a matter of law in Florida, chiropractors can use the term acupuncturist. So I wonder, how important is it to our veterans, our patients, the ones that we treat in the VA, that we continue to hew to the classic use of the term physician for only to refer to MDs and DOs? And I'll wait for your answer on that.
Thank you for your question. I certainly take no umbrage, Mr. Congressman. The statement that I made was that the definition by Merriam's dictionary and several other organizations is for physician is that they've passed the U.S. medical licensing examination. There are many doctors. There are doctors of chiropractic. There are doctors of physical therapy. That is by no implication lesser or more, superior or inferior. It is a definition. I don't think that, and so you asked how important that is. I think it's the least important aspect of this testimony or this bill. The American Academy of Orthopedic Surgeons, the Foot and Ankle Society, both agree that the VA it desperately needs foot and ankle care. So we have more in common, I believe, than we do differences. Let me make one clear point. The difference is There are 6 core competencies recognized by the AAMC, the American Association of Medical Colleges. Those 6 core competencies, one critical of those is systems-based practice. That creates the education, the basis for care of all systems. We're not trying to make something of this that it isn't. That is not one of the core competencies of the APMA or the pediatric education process. They have 6 core competencies, but they don't have systems-based practices. I really
So
would like to.
but the actual term physician isn't
I think the most important aspect
cow.
of this is that that our public and our veterans need to understand that there are differences in training. Make the decision.
All right. So let me just go to the second question then, also for you, Dr. Vicky. So you evinced a concern about, and we began to address this right just before, podiatrists as clinical leadership and certainly in academia, such as Johns Hopkins, it would be unheard of to have a podiatrist be the chief of orthopedics. But in the military, when I was a surgeon, I had commanding officers and leaders in the hospital who were medical service corps officers, hospital administrators for the non-military, and nurses and whatever. And I never felt that was a problem for me or my patients in terms of how we applied our clinical judgment or our surgical practices. And I think that you mentioned, Dr. Robbins, that in the VA, we wouldn't have a urologist overseeing an orthopedic surgeon, even though that sounds pretty good to me as a urologist. But anyway, so what was your concern about the clinical leadership, as it were? So is it okay to have a chief of surgery in a VA hospital who's not an MD or a DO?
Yeah. So yes, sir. I had addressed that concern as far as the leadership opportunities. We agree completely. Okay. There was a point in my career not long ago that I had no single physician in supervisory roles over myself.
I'm running out of time, so just let me say, Colonel, thank you very much again for being here, and thank you for the time you devote to our veterans. And I would seriously enjoy a chance to spend time with you in a smaller group and exchange ideas. I yield back, Mr. Chairman. Thank you.
Ms. Custer, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I wanted to direct my questions to Dr. Robbins. Moving on from the credentialing issue, we've had a great deal of discussion, most recently with regard to the Washington, D.C. VA, but I know this has been an issue all around the system about the delays for veterans needing prosthetics. We had a conversation just this week with our colleague Tammy Duckworth in the Senate about her own experience after her injuries and getting prosthetics and prosthetics that fit and prosthetics that worked and the delays. So could you comment about describing our national procedures currently and what we could be doing to make sure that our veterans who are in need of prosthetics can get those devices in a timely way, that they fit well, that they're effective for their quality of life? Any other suggestions that we should be focused on in this regard?
Well, I can't answer the question from the prosthetic side since I'm not a prosthetist or have any authority over prosthetics. I can address it from the provider side.
Okay.
So we will oftentimes need to work with prosthetics to provide a shoe with a special insert for a partial amputation in order to have that veteran ambulate properly. And so we will work very, very closely with prosthetics to provide that care. The variation in the prosthetic departments throughout the VA is quite significant. So we have some services that are outstanding. Some prosthetic services that work with podiatry get what they need when they need it. Others that don't have the same resources in order to provide that care. This is not something that is not something that we're aware of. This is something that we work on year after year to improve. the work with the prosthetics folks. But again, I don't run prosthetics, so I can't respond specifically to that portion of your question.
Is it who at the VHA would be in charge of that? Is that the chief logistics officer, or who works with the prosthetic companies to make sure that, I'm not so concerned about the companies, I want to know at the VA to make sure that these devices are available for your patients?
We have a department of prosthetics and rehabilitative care services.
And do you have any suggestions for us about improvements to that department?
If they're asking for more resources, they can absolutely use resources, because as we just heard, the VA is also having some issues getting well-qualified folks in prosthetics and orthotics that have the kinds of credentials that we now expect from those folks, and getting those people into the VA in order to provide that care. And also, and I think that the new choice bill addresses some of this, if I'm not mistaken, from my brief review of that, it also strengthens that relationship between the private sector, so that if we can't do it, we should be able to outsource it to someone who can, in time, just-in-time care.
Anybody else on the panel, and adding that dimension to it, should we be going the private route with prosthetics? Do you think we have the expertise in-house? Can we get it? What recommendations do you have for your patients to get the prosthetics that they need for their own quality of life in a timely way?
If I may.
Sure. Mr.
Yes,
Grant.
thank you. So as I testified, 90% of the prosthetics are provided from private providers outside of the VA, and I think that if there's an initiative to decrease that, then the VA would have to look at how are they going to increase the qualified providers on staff, and you have a similar type conversation that we're having about podiatry in the O&P realm. How are you going to attract, retain highly qualified CPOs or certified prosthetists, orthotists within the VA system? If the VA believes that that it is still the wishes to have 90% of that service provided through private contractors or outside contractors, then I think where, at least through my own experience, where I start to see some of those gaps is the facilitation of those projects or those cases as a need is determined and a veteran chooses a provider. It's largely the clinical protocol or the outcomes measures, those aspects of the care that you're seeing, as we too have sanctified over the years our educational requirements as prosthetists, orthotists. We are now master's degree holding practitioners with 1-year residency in each orthotics and prosthetics and pass board exams. We're also seeing, with the advent or the quicker movement of technology, we are seeing patients that are coming out of the VA want to come to a private facility. Most of our practitioners at this point have biomedical engineering backgrounds, and we're having to sort of interplay within the VA system where it's a bit hit or miss on the qualifications or the skill levels. It may be a bit more anecdotal, and that determination can many times come down to prior experience or what has worked in the past. And we're sitting there with protocols saying all we need to do is follow these, and it's not the be-all and end-all, but it's a start. Because as all of us, whether private sector or VA, we all are looking at evidence-based outcomes and having to support why we do what we do.
Thank you very much, and thank you for the elite thing.
Mr. Higgins, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Goldman, from your posture as president of your board, is a podiatrist capable of making an accurate diagnosis of diabetes based on if it's an initial examination where a veteran has been sent to that?
Certainly using the entire scope of what is available to us as laboratory data, clinical evaluation, we can certainly make that diagnosis. I mean, it is unfortunately too easy to diagnose, as we can all
Okay,
imagine.
I asked that because in speaking with veterans, and I represent a district with one of the highest density of veteran populations anywhere, certainly in my state, represent 133,000 veterans, and some of them that their initial symptoms that they noticed were foot pain and problems with their feet, and that led them eventually to a diagnosis of diabetes. So non-treatment of diabetes lead to cholesterol and blood pressure problems, loss of vision or vision impairment, doubles the risk of heart attack, kidney failure, neurological complications, and leads me to my next question, which will be for Mr. Brandt. Failure to treat diabetes also can lead to loss of lower limbs and amputations. People with diabetes have undergone 73,000 lower limb amputations on average each year, or roughly 60% of total amputations. And you stated, Dr. Brandt, we've just heard Dr. Goldman say that podiatrists can, a modern podiatrist can make an accurate diagnosis of diabetes. If you disagree with that, please tell me. But in your written statement, you stated that VA staff making decisions in some cases affecting lower extremity care appear not to be particularly knowledgeable about prosthetics and orthotics. Some VA prosthetic and orthotic clinicians welcome the partnership with private providers, while other VA staff seem to believe that some private sector providers are in competition with them for patients. So my question, Dr. Brandt, is how would you suggest the VA improve coordination and communication with community prosthetic and orthotic providers, and what are the costs to veteran patients if effective coordination and communication is not in place?
Thank you for your question, and to clarify for the record, I'm not a doctor, and I'll just, for the record, Mr. Brandt. Thank you.
Did I call you Dr. Brandt?
You did.
Well, congratulations, you've been promoted.
Number one, the first part of your question, I'm sorry.
I'm asking regarding the coordination with private. Regarding prosthetics and orthotics.
I'm sure the association. I'm sure the association definitely has a position, or could put a position forward on what could be done in the VA to facilitate more collaboration and coordination of care. As for me, my personal experience, that's a big topic. It ranges from the qualifications of those certified prosthetists, orthotists, or their credentials, to continuing education.
But you believe your organization could provide for this committee a specific recommendation regarding that?
Correct.
Could you get that to us down the line? I have one more question for you.
Yes, I can. Thank you.
Okay, and your testimony indicates that in an effort to reduce costs and eliminate fraud and abuse, the VA dismisses clinical recommendations made by community partners. However, you also state the VA often will make unnecessary purchases for prosthetics, which wouldn't benefit the patient. Could you speak more on that a little bit for us, please?
Right. So, excuse me, in my testimony, I think the easiest way to describe it is we see instances of overprescription and underprescription. And so this fits very nicely into outcomes measures, or attempting to baseline patients. There's ways to score patients regarding their functional levels, and then you can track that through the treatment of a veteran with limb loss, or any patient with limb loss. So once you apply those measures, it's not a silver bullet, so to speak, but it can contribute to your overall determination of matching componentry to functional level. So there are methods, and this is a big topic in our profession right now, which is advancing outcomes measures so that we can qualify and quantify why we're doing what we're doing. And it's not just based on things that we can't base decisions on that we might have in the past.
Yes, sir, thank you. And I'll ask, if possible, regarding both of my questions, could your organization perhaps provide to this committee within a reasonable time frame some specific recommendations that we may perhaps move forward to address both of these concerns? Thank you, Mr. Chairman. I yield back.
Dr. Abraham, you're now recognized.
Thank you, Mr. Chairman. For the panel, I am an MD by training. I graduated from the LSU School of Medicine in Shreveport. I've been very fortunate to practice medicine, family medicine, in the Louisiana and Mississippi Delta, treating thousands of veterans and certainly tens of thousands of civilian patients. And when I need a higher level of care, certainly in the lower extremity, I don't look at the initials after the name. I look at the name before the initials. And Dr. Fickey, you alluded to that when you referenced character. And whether you're an MD, a medical doctor, a DO, a doctor of osteopathic medicine, or a DPM, a doctor of podiatric medicine, the patients and the veterans, to your statement earlier, Dr. Fickey, about educating that veteran as to the different standards, the different educational training of those three different specialties. The veterans in the VA, they know. But again, the initials don't mean anything to them. These are all physicians in their mind and certainly in the minds of myself. Again, they want to be healed. And the definition of physician is one of a healer. We all, and Dr. Winstrup alluded to this, when we applied to our respective medical schools, whether it was MD, DO, DPM, we had to write out an essay, and if we were fortunate enough to get past the essay part, we got before an admission board, and the question was always, why do you wish to become a physician? And I assure you, for every one of us in here that are physicians, the answer was to take care of patients. That's what we do as physicians. So I think it's tragic that we're arguing over semantics for our veterans when we have such a disparity of economy in the VA system between what podiatrists and other physicians get paid. Dr. Fickey, Dr. Winstrup, you guys practiced your profession in what I imagine is the most trying conditions, where artillery shells were literally going off around you. In some cases, you were probably dodging bullets, but you did your job and you saved lives and you saved limbs. We've heard today where podiatrists, DOs, MDs, we can all do physical exams. We all understand, certainly you guys, your specialties and your specialties, you know bones, ligaments, tendons, nerves, blood vessels, and how they all are interrelated to the whole body. So, you know, I think it's unfortunate and, in fact, silly that we're arguing over this definition of physician between these three specialty groups of providers here. Whether it's a DPM, a DO, or an MD, we are all physicians. And the only thing that should matter here, especially for our veterans since 9/11, you guys have been under the most trying conditions, hundreds of thousands of patients. Unfortunately, hundreds of thousands of new veterans feeding into the VA system because of these ongoing wars that we have continuously. I think we actually need to come together instead of trying to fight each other here. And I understand, Dr. Fickey, as the USMLE doesn't recognize their board, but they have their board, and I'm sure it's as good as the USLME board that you took. You know, I think we're better than this. I think we forget that as physicians, our job, but not only that, our passion is to do one thing in this world, take care of the patient, and that's our priority. So semantics aside, you know, let's get this behind us. Let's get the podiatric profession in the VA up on the salary schedule, up on the respect schedule, and let's take care of these veterans. And I appreciate it, Mr. Chairman. That's all I wanted to say.
Thank you, Doctor, and appreciate that. I'm going to take another question here, and the statement was made about systems-based care, and I'm not sure where you think that's missing in podiatry. You know, as a podiatrist, I sometimes am the first one to find someone's hypertension, congestive heart failure, vascular disease, neuropathy due to diabetes or alcohol, take a skin lesion, find a malignant melanoma, all those things, I can tell you I have seen and been the first to suspect, do the proper tests, and make the appropriate referral to the specialist. That's what we do. I don't know where you're saying systems-based care is missing there. Yes, we have a scope of practice surgically that pertains to the foot and ankle, but it doesn't mean that the systems-based care and ability to diagnose or suspect or to order the appropriate tests, make the proper referral. That's what we do. That's what you do. That's what you do. If you took off a lesion on a foot and it was malignant melanoma, you're going to refer that, I would assume. And so I think we really need to take a look at this. As far as the definition of physician, I got, Webster's right here. A person skilled in the art of healing, specifically one educated, clinically experienced, and licensed to practice medicine, as usually distinguished from surgery. And in this case, we do both. Some of the definitions I looked, it gave the example of MD, but it didn't limit it to that. And so for us to be hung up on this word at the expense of veterans having a large pool of physicians able to take care of them, I think it's a shame. And I hope we can get beyond this as we move forward with this bill. And I know we'll have continued discussions. And I just want to finish by saying I appreciate each and every one of you being here today, because I do know that it's on behalf of veterans that you are all here. And we'll move on from here. And I want to thank you again for attending today. And Ms. Brownlee,
I just have one quick question. And my question really, I think, doesn't directly relate to the essence of what we're talking about here relative to the specific bill. But Dr. Robbins, I just wanted to ask you, I wanted to go back to the salary schedule again. Yes. And if you could tell me how the VA determines the minimum and maximum allowable salaries for physicians, for dentists, and then how do they do the same determination for the minimum and maximum allowable for podiatrists? Are they different or are they the same?
Yes, they are different as of 2006 when the Physicians and Dentists Pay Bill was passed. The physicians and dentists moved into different tables and tiers, and the podiatrists stayed in the same GS 12, 13, 14, and 15 categories as they had been, again, since 1976. Within that process, the physicians and dentists are boarded locally, where in podiatry, we are boarded nationally. And I am actually the chairman of the National Podiatry Board. And qualification standards are issued, and the ones in podiatry are from 1976 in VA Handbook 5005. And it's scary that I know that. But that is the directive that information comes from. So we are obligated to use those qualification standards in order for us to provide a grade and rank for podiatrists, so much so that in the past 3 years, we've had to go through there and write equivalencies to bring it up to 2017, because a lot of the stuff written in 1976 doesn't really apply. So we had determined equivalencies, which is a document that we use as the qualification standards now.
Thank you. I guess my question was relevant to, to the essence of what we're talking about today. And just what, one final question quickly is, how many podiatrists are really expected to retire from the VA in the next 10 years? And do we have a succession plan in place to hire, to fulfill those jobs for the current and future needs?
We have a significant number, I don't have the exact number, but we have a significant number of people I call less young that are approaching retirement age and that are going to retire. And many of those folks are the mentors and the residency directors. And someone talked a little bit about access a little bit earlier. That has a profound potential negative effect on access, as the more experienced providers who can deal with more complex problems, see patients more effectively and efficiently, are leaving the system, and younger providers who don't have the same experiences can't see patients as effectively and efficiently as those providers. The best system, of course, is when you have mentor and mentee and develop that kind of succession plan. What we are hoping from this legislation is to give us the opportunity to start recruiting some of those mid-career folks who have board certification, have those experiences to act as those mentors for our younger folks. That will provide us with that succession planning that veterans deserve.
Thank you, and Mr. Chairman, I yield back.
Any other questions? To the panel, I want to thank you all once again for a good conversation today. If there's no further questions, the panel is now excused. Again, I thank you all for coming, and I ask unanimous consent that all members have 5 legislative days to revise and extend the remarks and include extraneous material. Without objection, so ordered. The hearing is now adjourned. Thank you. Here's one.